You are now listening to Nailed It, the Orthopaedic Surgery Podcast.
All right. Well, got the game back together again. Thank you all for coming, tuning in to another show with us for the Spine Citations with the Nailed It Orthopaedic Podcast. So, hey, guys, let's introduce everybody. Hopefully you know me by now. I'm Jay. I'm one of the hosts of the Nailed It Podcast. I also have two amazing guys with me here. Sohum.
Hey, everyone. How you doing? I'm a PGY2 resident in Indiana. Excited to be on the podcast and love the topic we're going to be talking about today. Thanks to Jose for the wonderful suggestion.
My pleasure there. This is Jose here. I'm a medical student at the American University of Integrated Science in Barbados. Looking forward to this exciting topic.
Yeah, this is a good one. I feel like this is something that's probably not, a lot of people probably don't really get into it as much because it's so specialized that, only certain people even seeing these types of pathology. So I'm glad that we taking the time to go into metastatic disease.
Okay, as mentioned, our topic on this is about metastatic spine diseases, and basically it's the most common kind of cancer is in the spine. In the etiology of this, it could either be spread by hematologic or lymphatic approaches. That usually depends on which kind of type of cancer there is there. In addition to spread to the vertebra, a lot of times these cancers will spread to other parts of the bones there, especially long bones there, and usually many times these spread to these bones can result in pathological or compression fractures. And basically the easy way to know is that sometimes even fractures occurs when even doing simple movements, which we will find very odd to have a fracture, and even simple movements, usually non-traumatic fractures to be more specific there. And usually treatment is a multimodal involved in many kinds like surgical, radiation, chemo, and later on in the presentation we'll introduce some other kind of treatments available there that'd be quite an option depending on the nature of it. And in addition to other types of most common origins of these cells could be usually prostate, breast, colon, skin in the case of melanoma, renal cell carcinoma, lung, and a few other places. Usually these are the common where basically spreads into the bone there. And also a special note you must take into consideration that sometimes even infections like osteomyelitis and tuberculosis can oftentimes mimic as a malignancy on imaging. And that's why it's very important to have a biopsy as the gold standard to ensure that to rule out a malignancy. Once malignancy is ruled out, then you can consider other etiology there. And basically, the one key thing I want to mention is that a lot of times these metastatic diseases are oftentimes found incidentally, which usually are oftentimes looked for something, but eventually upon imaging they are picked up incidentally. So, and that's how they usually are found a lot of times there.
Yeah, I think that those are all great points, Jose. And this reminds me of one of the previous Nailed It podcasts that I listened to as a medical student. That was about working up osteolytic lesions. And what I remember from that podcast was the differential in an adult patient with a newfound lytic lesion. It's metastatic disease, myeloma, lymphoma. So metastatic disease by and far makes up the majority of lytic lesions we see in both, the axial and appendicular skeleton. So a pretty high yield topic. Go ahead and kick things off into our first paper. So this is a landmark paper that is kind of the cornerstone on a lot of what spine surgeons' role is in managing metastatic disease. This is a multi-institutional prospective randomized controlled trial published in The Lancet in 2005 by Roy Patel et al. Out of Kentucky. They were comparing surgery plus radiotherapy with radiotherapy alone for metastatic epidural spinal cord compression. So a little bit of background on this topic. When this paper was, put into motion, this was probably in the early 90s. The standard of care for metastatic epidural spinal cord compression or metastatic disease of the spine was high dose steroids and radiation. Surgery had a very limited role. A lot of this had to do with the fact that in the past, all they were doing was just a posterior decompression with laminectomies, regardless of where the metastatic disease was located. So, critiques of this were, how are you judging the efficacy of surgery if all we're doing is laminectomy when a majority of the metastatic disease happens to be in the anterior, 2/3, the anterior two columns of the spinal cord or the spinal column. So, at that point, people started considering circumferential decompression, and there were some retrospective studies that showed promising results with, wide decompression in the 80s and 90s. So what Dr. Patel wanted to look at with this study was, determining a role of surgery with a randomized controlled trial without any selection bias, and establish the role of surgery in managing metastatic disease, essentially in conjunction with radiotherapy. So they enrolled about 120 patients from several centers between September of 92 and December of 2002. A few of those patients were excluded for reasons, that are highlighted in the method section of the paper. And they ended up with about 100 patients total. And they randomized them to two groups and used an intention to treat analysis throughout the study. All patients got the same dose and timing of steroids and radiation, and the surgical patients were operated on within 24 hours of randomization. These patients were followed up at regular intervals every 4 weeks until the end of the trial or death, whichever occurred first. The primary endpoint of interest was the ability to ambulate. So they wanted to see how, these intervention influenced a patient's ability to ambulate. And there was several secondary outcomes they looked at too, which are highlighted in the PowerPoint. So interestingly enough, and this is almost the first time I think I've ever encountered this in the results. They had such a significant difference in their results. The ambulatory rate in the surgery group was 84%, compared to 57% in the radiation alone group. And the p-value is so low, it was 0.001, that it met criteria to actually stop the trial early because of how superior surgical treatment was. It was deemed that it was unsafe to allow patients to have just radiation alone. So this was a huge turning point in the management of metastatic disease, that they had to stop the trial because surgery was so much more successful. And you can see the Kaplan-Meier curves on the slideshow if you guys are watching along, that the patients who underwent surgery had a significant longer period of remaining ambulatory, and also the patients who were ambulatory at the beginning remained ambulatory after treatment for a longer period of time. So those are both significant results. And also all of the secondary outcomes were statistically significant, including maintenance of urinary continence, Asia motor score, Frankel scores, and survival time, which is, pretty serious. And, some people might say, well, patients with surgery may have been in the hospital longer, but the surgery did not result in prolonged hospitalization either. So overall, statistically significant, very important results early on in the study. So the conclusion that they came to is that surgical treatment in conjunction with radiotherapy for metastatic epidural spinal compression in appropriately selected patients resulted in the ability to lock for longer and regaining the ability to walk more often, as well as increased survival time. So, their final conclusion was that the best treatment for spinal cord compression caused by metastatic disease is surgery initially, followed by radiotherapy. But they did highlight that, reasonable clinical judgment is necessary in the selection of patients. And, there was a few of their exclusion criteria that they highlight that should be applied when considering surgery. And we'll talk about some more papers here that kind of help guide patient selection. But I think the take-home point for this is in the appropriate patient, surgery plays a critical role in managing metastatic disease.
Absolutely. And just like you highlighted, man, I think this paper was, like you say, is really key. Two things, we don't have a whole lot of randomized control studies in orthopedics, so they were already all onto something with that. But like you say, the results were so so positive towards one way that they decided to stop the entire study. I mean, that lets you know how good of a treatment plan this is, and I think that's why it's likely has become one of the key operative treatment plans for these types of patients. So awesome. Our neurosurgery colleagues did a great job on this one.
Yes, sir. So we'll move it along to another classic, by Dr. Takahashi. Let Jose take it over.
Thank you there, sir. As Dr. Patel mentioned, that presenting this next paper on basically the outcomes and preoperative evaluation prognosis there. This was a preceptive study to evaluate outcomes in spinal metastasis using a specific kind of prognostic scoring system. And this was published by Dr. Takahashi et al. That was on Spine 2008. It was completed at the Department of Neurosurgery at Naho University in Tokyo, Japan. So, since we're give a little background here, we would see that there were in the previous prior to this study, because there were some limitations on the ability for how to a kind of system in place for metastatic tumors, because prior ones they really had a good system in place, particularly with prognostic figures there. But however, Takahashi here did propose a system in place since 1987, which he published a paper on it, and which was validated since. This was and you can see from the table here, shows you how the point system breakdown there. And in the next slide, I'll explain how this point system value is determined its prognosis there. And so, having that said there, this study is attempted to determine the strategy for the metastasis as a base for prognostic scoring along with treatment there. So how they determined such a study like this there? Well, what they did was that they take about 183 patients were selected for it, and they were all scored based upon the prognostic diagnosis as mentioned earlier. And you can see in Figure 1 there, it shows you the breakdown of the score there. What gives you, and below the score, it gives you the predictive prognosis for each one of them, these in each group there, and the corresponding treatment options there. Like, for example, if someone has, like, say, a prognosis score, let's say, of 10, and knowing that his prognosis was less than 6 months, chances are he's going to schedule surgery there, and as such. And then, in addition to it, for each one, so it will be divided into different groups, either conservative treatments or palliative surgery for prognosis less than 6 months, or in those multiple virtual metastasis. Excisional surgeries for those who have one or more year of prognosis, particularly of 6 months or more, in a singular vertebra. And of course, these patients, the outcomes were scored based upon the vast pain, activities, daily living indexes, and physical examination to monitor pain relief and check on paralysis. So, in result there, it showed that that this system in place there that Takahashi had shows that 85% were predicted the prognosis there. In addition, they shown that of those the survival period for each one shows that 87% has score of between 0 to 8 in 6 months there. For those with a 6 months or more prognosis, were 87% scored between 9 to 10. And then for the 1 year was around 95% there, with a total score between 12 to 15. So it kind of shows that it has some good outcomes in this, in terms of not just for the system in place for just for the prognosis, but also corresponding treatment there. And as such, the prognosis criteria and survival period was more than 87% there. And of course, that when monitoring the examination for paralysis and even pain relief there, paralysis was shown that it was about 76.9% in the incisional group, and 81.1% in the palliative group, and then 61.1% in the conservative group. And then they showed that there was no issue, corresponding in terms of pain relief there, as shows that it was monitored very strictly there because of the certain modalities involved there. So in conclusion there, And so, before I do that, let me show you some of the graphs here. Basically, it shows you that the Hahn monitor goes there with the divisional groups where shows that how shows the improvements of these scores based upon the treatments that are involved. So it has done this. So in conclusion, this has shown very effectively how to determine for the system in place for using life expectancy, as well as when correspond to the correct treatment method. Of course, the author made a note here saying that some revision might be necessary for improvement of these evaluations and based upon new treatment modalities and various. Because if you notice from some of these treatment options that other didn't have really much of other adjacent treatments, particularly like say radiation, chemo, for example. But it has expanded more. So thus that does recommend for change any revisions in the evaluation. However, we could say based on this study and the results shown that this is very appropriate, as well as also a first prior given system in place for those for predicting prognosis, as well as give advantages and limitations of these treatment options there.
Nice. Yeah, man. I think that this study has the two goals of me choosing this study. One was to introduce the Takahashi scoring system. So in 1989 and then again in 2005, I'm going to jump back a few slides just to the scoring system slide, just to emphasize this. This is what he came up with first, was evaluating the prognosis. So based on these factors, which are highlighted in the table, they predicted how long somebody with metastatic disease to the spine would live. So they had that figured out. But the question is, okay, so now that we know how long these people are going to live, how do we know our treatment or what to do in terms of treatment? Like, who do we operate on? Who do we not operate on, essentially? So that was the purpose of this, updated paper in 2009 was, now that they had the scoring system, they wanted to use their scoring system to stratify treatment. So that was essentially what they showed, was that, their scoring system would, serves as a good guidance to provide, treatment options for patients with metastatic disease. So I think that, primary take home point is one, knowing the Takahashi scoring system and what it means, and then, its implications for treatment as well.
Yeah, I agree. A lot of the papers that you see with, there's a couple different scoring systems. We're actually going to talk about another one, I believe, in one of our papers. But, as far as the treatment, it all is a lot of it has to go back to, prognosis of that patient. And I don't personally have a lot of experience with oncologic spine patients, but seeing in these papers that how important the prognosis is, and it's not just about, the symptoms that they're having, but what is the overall expectancy of these patients in the long term, even with the given treatments that's available. So really did like this paper just because it highlighted that whole portion of the algorithm when you're thinking about how to treat these patients.
For sure. And now we'll jump over to a realm of unfamiliarity for all of us.
So for the next paper here, it's basically on a very unique approach to it. Although this is a very common area found in neurosurgery there, but this shows how it's used in the area of in spine surgery for use of radiosurgery. And basically how this approach is basically a prospective non-randomized longitudinal cohort study to evaluate clinical outcomes of using fractional radiosurgery and for the metastatic spine tumors. This was by Ginston et al., published in Spine 2006. And the study was done in the Department of Neurosurgery and Radiation Oncology at the UPMC in Pittsburgh. Okay, just to give you a little background about it, because as mentioned earlier, this area is more aligned to something you see in neurosurgery, because there has been great amount of research of this about it, but there has been some few in the areas of in orthopedic spine of how this works out here. Basically, a little bit of background. This option is is basically it will give you a high dose radiation delivering a single fraction to areas usually around the brain area in this case, or in the spine area, and it's very effective in controlling malignancies around the brain there. So this has been shown that in terms of the brain metastasis, and even radiation there had a control rate in between 85 to 95% there. And one note I want to bring out here is that this kind of option treatment is very well, particularly in areas where if the tumor is reaching the areas that are very, very difficult to enter through regular excisional surgery. Like, for example, maybe it's real deep into the parenchyma of the brain that may affect surrounding delicate structures like maybe the brain stem, or even sometimes the vasculature, or even the nerves around it. So not taking any chances, since the risk is greater than the benefit. So this is an option they will do in order to as a way to an option to help out this problem. And what they usually do is that it gives a good tolerance. This kind of option radiation dose around the tumor is very low tolerance of the spinal cord to the radiation, particularly without causing any kind of myelopathy towards the spinal cord. That's the benefit of the fractional over the ear fractional, because the ear fractional gives a higher dose there, and it can cause issues with the spinal cord there. And then patients with high static complaints are usually debilitated and high risk for surgical mobility, as I mentioned earlier. Usually with limited life expectancies and underlying diseases, as well as high surgical complication rates with subsequent decrease in quality of life, are most unacceptable. So basically, it's mentioned earlier that if it cannot be reached with normal surgery, then this is an option too. And then real quickly here, this slide here shows demonstrating some options here of rheostatic turn. On the left side of your screen there shows a rheostatic surgery, or gamma knife as commonly called. You may have heard about it, where basically just show beams of radiation through the area, and the cyber knife does very similar to it, except the only difference between the two here is that gamma knife is zapped in one particular area, different certain angles around the area. Because a lot of times these gamma knives, they're usually placed in this machine, as you can see in the picture, with a brace or some kind of a mask over the head to protect from the radiation. Whereas cyber knife you see here can go all around the head without worry about, because it's almost very similar to, like, say, a proton therapy for certain cancers there. Very similar to go all around without worrying about and the amount is very little, so not worry about any complications compared to the gamma knife there. So the method with what they did was they did a cohort 500 cases of that underwent radiosurgery there. And of course, they used to make the proper diagnosis, they used either CT or MRI to make the diagnosis. And for the cyber knife we use this, which consists of three things. They just used the CT imaging with the landmarks and other bony prominence there, as well as the planning and the treatment itself there. And they also had documentation to monitor pain management, because of in order to monitor of these pain meds because of high anesthetic uses there. And this slide right here will show you just the image will look like when using the cyber knife. The cyber knife here, it shows basically in figure one, you see how it ranges around to basically computing process, kind of like very similar to as if you're doing like a robotic surgery for like joints or spine, for example. Very similar approach. It basically gives you a planning approach, and it's also it gives you an idea where to hit in a particular area, in areas of focus there. Now in the bottom screen here, in the bottom portion there, in the bottom picture here, when I was looking through more about this information, I come across a paper written by Cox and All in 2012. Dr. Cox was a radiation oncologist from Memorial Schools and Kettering Cancer Center in New York. He published a paper where he talked about using gamma knife for spinal metastasis. And this picture here from the article shows you the approaches, how he did it in different angles and different stations for each level of the spine, like the cervix, the thoracic lumbar area, just to give you just a quick idea on that. And the results shows that the radiosurgery was very effective in decreasing pain in these kind of patient populations, as I mentioned, because they're very difficult because of the nature of it and their delicacy. And it showed the improvement, the pain improved at 86% improvement. And as well as also demonstrate 96% of the women with breast cancer, 96% with melanoma, 94% cases with renal cell carcinoma, and 90% of lung cancer cases. Overall, long-term tumor control found to be at 88% for all cases there. So this is what I was mentioned earlier about. This is a great option for those if it cannot be surgically resected or whatever, if it can be done here. So this is one great option as a treatment option in place for, say, for example, for surgery or radiation chemo. So this is something to consider in this particular area. So the conclusion shows that single fraction radiosurgery is both safe and clinically effective, as we mentioned in the data, in the results there. The major potential ablation benefit for this is that it has very short time, usually in a day in some cases, and it can be done in outpatient setting, and potentially better local control of tumor and minimize risking side effects. And even in some places they offer this service. A lot of times they could be classified as outpatient services a lot of times. So this is something very, very something great there to have there. In addition, it allows the treatment lesions previously irradiated using conventional external beam irradiation, as I mentioned earlier, about because it senses a very low quantity of radiation compared to standard radiation or even other treatments. This is something that could be very much safer, and as well as also a more effective way to reach without even the fear of causing further serious complications in the near future.
Yeah, nice. I think that this was something I didn't know anything about at all. Like as you mentioned, it's primarily neurosurgeons and radiation oncologists that use this, but it's part of the multimodal treatment of these patients. And as we'll jump into on the next paper, it takes a village, right? It's complicated. Cancer is a complicated disease process. We need to work together with our radiation colleagues or medical colleagues, and and take the best care we can of these patients. I thought it was interesting just to shed some light on a aspect of this that I'm not so familiar with.
Yeah, and I actually did see a question about this before on an Ortho Bullet, so it is something that comes up and definitely can be, I think, like both. Well, definitely Jose. I know Jose mentioned it. It can definitely be a good option for individuals who may not be healthy enough to undergo, some kind of major debulking kind of surgery or removal of some kind of tumor, and also, maybe if the actual tumor itself is very radiosensitive, that this may be an excellent option as well. So definitely seems this is definitely worth reading. I appreciate that we brought this up today.
Yeah, and I mean, and another thing that too is a lot of the patients that have metastatic disease, like a lot of these things that we talked about, like the Patel paper and Takahashi, they're not doing surgery on people that have massive widespread metastatic disease. You can't provide tumor control, debulking, or you can't deburden the tumor, if it's everywhere all over the spine. So that's where this, these type of different multimodal treatment options are also, I think, high yield, people that aren't great candidates for resection, like you mentioned. All right, so jumping into the last one while we're on the topic of multimodal approaches. This is called the NOMS framework. So this is a group out of the Sloan Kettering Cancer Center in New York that did a literature review on implementing a systematic treatment of metastatic spinal disease with what they call the NOMS approach, which is an acronym that stands for neurologic, oncologic, mechanical, and systemic. This was published in The Oncologist in 2013 with the senior author, Dr. Laufer. And this is, again, the Department of Neurosurgery. So learning a lot from the neurosurgery colleagues today. So a little bit of background and kind of just touching base on why we chose this paper. The goal of the group of these authors was to provide a dynamic framework, in a field that's constantly evolving, to treat spinal metastases. So, they wanted to see how we can combine medical optimization, chemotherapy, radiation, surgery with host characteristics of the patient to come up with the best treatment plan. So they wanted to incorporate all the technological advances and multimodal options. And they developed the 4 components, like we said, the acronym: neurologic, oncologic, mechanical, and systemic. So they determined the different ways to assess each of these things. The neurologic assessment was based off of 2 things: radiographic assessment on the epidural spinal cord compression, and clinical assessment if a patient was myelopathic or not. So, the paper highlights how they specifically grade their degree of epidural spinal cord compression. I'm not going to go into that, but it's just a scoring system essentially, which is invalidated. And then the myelopathy was a clinical diagnosis. The oncology component was, the expected response of the tumor to available treatments like external beam radiation, stereotactic surgery, chemotherapy, immunotherapy. But the primary focus that they wanted to hammer in was the radiosensitivity of the tumor. And a little knowledge bomb they dropped that I thought was interesting was that, that what correlates the most with the radiosensitivity is the histology of the tumor. So we often forget about the pathologists of the world, but they're doing their job in their multimodal approach for us here in the spinal metastatic disease world. And then the mechanical component was basically determined by stability using the spinal instability neoplastic score, known as the SINS score. I've included a picture, but essentially this incorporates the location of the tumor, patient's pain levels, the type of lesion, alignment, vertebral body collapse, things like that, to come up with a number. Basically what you get is unstable, stable, or indeterminate. So that's your mechanical component. And then the systemic component is the patient's host, innate medical comorbidities, and their ability to survive and expected survival, which includes different prognostic scoring systems. It doesn't include the Takahashi, but that would be an example of a similar type of scoring system that would provide that type of information. So essentially what they came up with, this chart is kind of just a summary on how they approach this. So, you can see the 4 columns: neurologic, oncologic, mechanical, and systemic, and then their decision. So they look at the neurologic components, whether it's a low or high grade compression, whether or not the patient is myelopathic, the radiosensitivity or radio resistance of the tumor, and then the stability determined by the SINS score. And then lastly, the systemic host characteristics of the patient, and then that guides their decision making, whether they think they're a candidate for radiation plus surgery, alone, stabilization, et cetera. So they came up with a nice algorithmic approach. And in orthopedics, we do like algorithms. So I thought this was an interesting thing to include. So essentially the conclusion, this isn't, super groundbreaking, but it's, they provided a framework for people that see spinal metastatic disease to optimize patient care, that involves, a multimodal approach, interdisciplinary approach is probably the appropriate term. And, they wanted to emphasize tumor control and minimize morbidity from treatment, but also be as effective as possible using pharmacology, radiation, and surgery. So it's important to consider the stability, the degree of epidural tumor extension, and then, the histopathology, which relates to the radiosensitivity, and then the patient's medical comorbidities itself in determining how to treat their metastatic disease. So I think this is a good read, just to kind of open your eyes on interdisciplinary approaches to treating patients.
Yep, and I don't have a whole lot to add, but I did like the diagram there. Us orthopedics, we like diagrams and pictures. So I actually did think that if you kind of go through it, it kind of sums everything up and makes it pretty simple to follow. So just like you said, I kind of like the multi, the multi approach that we're kind of taking with this, kind of taking into effect all the different various factors that come into play. And overall, I enjoyed all these papers, guys. I think these papers were awesome. I learned a lot. I think there's a lot of highlight on, and I'll see if you guys agree, but sounds like, spinal cord compression pain, and instability, along with prognosis, of course, seems to be some of the hierarchy things to keep in mind when you're treating these patients.
Yeah, I think it's nice to read some neurosurgery literature and learn, it's a joint effort to take care of spine patients. So it's a little, I think that orthopedic literature, and this may or may not be accurate, but based on what I've seen in residency, we have a pretty structured approach to reading papers. We have pretty frequent journal clubs and, very regimented curriculums in our residency with things like orthobullets and stuff. And I'm not, at least based on talking to my buddies who are neurosurgery residents, I'm not sure, they take the same academic approach. Obviously their residency is academic, but they don't have such as, structured things like orthobullets. So, they have their journal clubs. That's how I got some of these ideas from, was actually they suggested they have pretty infrequent journal clubs, but they touch over these big landmark papers. And so that's kind of how I came in contact with some of their literature, I think.
Oh man, I think you did a great job. Always good to kind of get different points of view of things, for sure. Matter of fact, I probably should start trying to find someone to let me into one of their journal clubs whenever they do it, because there's so much overlap between ortho and neurosurgery. Of course there are some things that they do that we just don't touch, and they may have a little bit of a different opinion on certain things, but it's just good to hear the other side. And for people who are interested in spine, and if you go into a fellowship, maybe that's something you look for, is where maybe it's a combined or joint type of fellowship between orthopedics and neurosurgery, or at least you guys work together a lot so that you can kind of get two different sides of view on things, for sure.
Indeed. And sometimes in some fellowship programs, depending where you go to, oftentimes they have faculty that are both ortho and neuro sometimes. So you're looking into basically one side looks in different approaches and parameters, so forth there. Even though they're very similar, as mentioned, but of course the approaches a lot of times are quite differently. Because I myself I did 2 rotations in spine, one with an orthopedic and one neuro. They're very similar in very pathologies and so forth, and even surgical devices and so forth, but obviously there's quite obvious differences in how their approaches and their management as well. But generally speaking, overall, they're all taught the same there.
Awesome points. Well, guys, I guess we can wrap it up. Again, I thank everybody for listening in with us. If this was your first time tuning in, we have more to come. These guys are putting out great material pretty often now. And we also have a slew of other groups that's putting out different papers on different specialties as well. So keep an eye on that. We still have the podcast going. Just make sure to subscribe on any provider you have for your podcast, as well as YouTube. And we hope to see you back next time.